Hi, this is another short video on the RAS-DS. This time we are focusing on how to use the RAS-DS to enhance the recovery orientation of your practice. So before we start, I'm just going to give you a bit of an overview of what is captured or what is explored within the RAS-DS. It's split into 4 domains of recovery, and it also explores has items or questions that try and span early, middle, and later sort of stages of recovery. So in terms of the looking forward domain, we're talking about those aspects of recovery where someone is moving from a stage where they may feel a lot of anguish, but certainly feel hopelessness and see themselves or view themselves as a sick person through to a point where people describe being in control of life, having good well-being, feeling hopeful about the future, and viewing themselves as separate or external to their experience of illness. The second domain the second domain that we explore in the RAS-DS is labelled Mastering My Illness. So it's more about symptom management than a kind of understanding of clinical recovery. So people moving from a place where symptoms are really dominating and impacting on life through to a place where they talk about experiencing control over their symptoms, or gaining control over their symptoms, managing those residual symptoms if they exist, and that symptoms having a lesser and lesser or more minimal impact or interference with the ability to live the life that they want to. The third domain that's captured in RAS-DS is social recovery, or called connecting and belonging, and people talk about in the early stage of recovery having very few relationships, and those relationships being ones that they can depend on, and mostly the relationships with family and potentially with us, with the healthcare providers. But moving through to a place later in their recovery where their social network expands and becomes much more diverse, people talk about the need to have both lived experience and non-lived experience people in their network, and that's captured within the RAS-DS. They talk about it being obviously with family, but a much broader communities of connection. The quality of those relationships also change. So people talk about more reciprocity, and where they are both the givers as well as the receivers. They have relationships where they're needed and relationships that they need, and that they're personally satisfying. And finally, the doing things I value domain, people is really focusing on people's journey from a place where they're disengaged or inactive, and maybe need to be at that point, where they talk about a poverty of activity or role engagement, and again where the sort of sick patient role dominates their sense of who they are and what they do, through to a place where people describe doing things that are personally, not socially necessary, but personally valued and meaningful to them. And they have this sense of contributing to and being needed by others through what they're doing. So that's the structure that is captured within the items of the RAS-DS. So now let's talk about what we mean by recovery-oriented practice. I'm going to be really simplistic here, but I think these are the key components that I'm going to try and link to using RAS-DS. So one is being strengths focused, so focusing on what people can do and want to do, not on their deficits, and also coming from a hopeful and optimistic space where you have genuine hope and optimism for people's futures. The second one is that you have an individualized approach, so that it's not a formulaic, this is what I do with people with this diagnosis, but an approach practice, where you are really getting to understand who is this individual and what is important and unique to this individual, what are their dreams as well as their goals, and tailoring what you're doing with them directly to what's important with them, and not doing to them, but hopefully doing with them. And third, that it's collaborative. So you work rather than in a dictatorial kind of way, you're working in partnership and collaboration with the service user or consumer, and you're facilitating and supporting them to gain and take and embrace ownership and self-determination. So rather than you leading their recovery, really facilitating people to drive their own recovery. So that's recovery-oriented practice. And I'm going to talk about how the RAS-DS can be used to really, as a tool to support you as much as the consumer or service user. So it's supporting them in their recovery journey versus supporting you in terms of how recovery-oriented you can be in the way you practice. So I've put up this simple structure because I think I think regardless of whether we are peer workers or occupational therapists or community mental health workers or nurses, we all follow to some degree, and we might use different language, but we follow this same kind of process in the way we work with people. Step one, first phase, is actually getting to know and understand who the person is that we're working with. And we might call that assessment or we might not, but it's this getting to know the person phase. That leads into goal setting goals, whether they're intentionally set or not, that there is a process of what are the goals that we're going to work towards. The next phase being the intervention or the process of working with the person on what's important, hopefully to them. And then the final phase being an evaluation or review to see it, to find, is what we're doing working? Is it being effective? Is it meeting the person's needs? And based on that knowledge, going back. So it's a cyclical process. So this is if we use this structure to understand this is the flow of mental health practice, regardless of our training or our orientational background. Now I'm going to apply the use of RAS-DS to this. So if we look at using RAS-DS as a part of, or a major part of, hopefully, the getting to know the person phase of our work, it can really facilitate a deep understanding of who the individual is. It also engages the consumer or the service user as a very active participant in the assessment phase, or the understanding what's going on and what's important phase of our intervention or our process. Here are some quotes that I've got. MHW stands for mental health worker and SU is service user. So here are some quotes. Again, they're kind of themes of many other people's quotes. So this is from a study we did in 2015, and it's simply capturing one quote that articulates the voices of many. So mental health workers describe things like doing the RAS-DS at this point in time helped unearth issues that hadn't been discussed before. So it's interesting because a lot of the people in this study had actually worked with the consumers or service users that they were using the RAS-DS with for a long time. So it wasn't as though it was a new relationship. So particularly interesting. And other comments that very useful, got to know a lot about them and their recovery. The service user quotes, these are the themes that came out of service user data. They talked about my case manager understood me and I understood me. I love that. So it's this kind of, I gained a deeper understanding of myself, but also they understood me. It helps me understand my life and my recovery journey better. And I think really importantly, consumers or service users talk regularly about this kind of, it helps to talk about stuff. It made it easier to have conversations. It it gave that little step needed to bring up things that they weren't feeling comfortable to bring up beforehand. So this assessment phase, typically in Australia, and I don't know, I assume it's pretty similar globally, but certainly I'm going to talk from an Australian perspective, and that is most of our assessments that are used in this stage are clinician rated or workforce rated. So it's us making an assessment of them. And if we think of recovery-oriented practice being all about how do we partner with, and I don't really like this word, but empower or engage and facilitate service users to shift from being passive recipients of what we do through to being really active and taking a leadership role where they can and driving their own recovery. Unless we have genuine participation of a service user at this early point in the assessment point, when we get through to the setting the goals stage, goals are set based on what we found out from the assessment. So we can see that the flow into goal setting, unless there is genuine participation by the consumer at that getting to know you phase or assessment phase, then they are already excluded. They're not part of that partnership that will move into genuine and collaborative goal setting. But when they have been, then that data from them, their voice, their self-report can inform the goal setting. So this is some quotes around goal setting from data from consumers and mental health workers using the RAS-DS. So some of them talked about the great points to think about in relation to goal planning. And so some people sort of peripherally reflected. I think that sort of great points to think about really is they're sort of there, but we're not intentionally bringing them across, and we're not intentionally reflecting on them and using them in goal setting. Whereas the second quote, I think, does say that that captures those mental health workers who quite intentionally and actively use the tool, use the ratings and the conversations they had with consumers around the RAS-DS to directly inform the goal setting. And when we looked at consumer data or service user data, they didn't talk about it being intentional or direct. And so we actually got a lot of data from service users saying, wish I had, I wish I could have, it would have been good if we'd have used what I did there into goal setting. So I think that flags that there's some work to do to help us, for us all to intentionally and actively use those to think about, okay, based on this, what's meaningful, important to you, and what do we use in terms of setting goals? And the last one on this slide is really looking at evaluations. So there were just these comments came from service users, and this is one quote to capture service users talking about the value of being able to look at scores over time. And so this quote is saying, it helped me notice the big change in the way I'm thinking about recovery, and a positive change. Okay, so that's all of them. But I think whether or not RAS-DS actually is a tool to support how recovery oriented you are in your practice completely depends on the way you use or how you choose to use the tool. So if we used the tool as I'm about to describe, so the service user completes it at the beginning of the intervention, the data is captured and it's stored in the records securely, and then the service user completes the RAS-DS again after they've completed the intervention or the program or whatever it is you're delivering. And then the data is drawn together so you can compare time 1, time 2. Then we're really looking at using the RAS-DS as simply as and it's not negative in terms of if you're choosing to use it simply to measure outcomes of your service. So does your service, does the program you deliver result in change scores in terms of a person's recovery. That's what you're capturing there, but you're not doing anything to enhance how recovery oriented you are in your practice. But let's look at this sorry, I just need to move that out of the way. Okay, so alternatively, if we're using it in this way, it's quite different. So the service user would complete the RAS-DS before or early on in their involvement with you and the program that you're delivering. The time is then made to really sit down and discuss and explore the results, and you are showing genuine curiosity to really understand what from their lived experience and from their perspective, how their recovery is going, and also finding out what's important to them, which of those items are most meaningful. So what are their priorities? You're then bringing that quite intentionally with them to making sure that those priorities they've identified from using the RAS-DS and through those conversations are brought into the goal setting process, and they directly inform the writing of goals, and those goals being written in first person ideally, right, but absolutely owned by the service users. So they should be their goals, not the service goals, but the consumer or service users' goals. Then those goals directly and genuinely driving the actions that follow, so that it is those goals that are owned by the service user that lead to the intentional actions that follow, and that's your intervention. We then, at some point, for some people it will be not at the end of the program, but it might be once every 6 months if it's a longer term sort of service or support program. But anyway, the service user will complete the RAS-DS again at a later date, and that gives the opportunity to then compare and look at the results between time 1 and time 2, and then maybe you have a few over time, and you can really look at, so what's shifting here, what's not shifting here, let's talk about this, let's talk about why this is, what's the background to this, and what's happening in life to make these change or not change, and therefore what do we think we want to do next, and then the cycle comes back to here. So really understanding, we've got, please feel free, at the end of the slides you'll see our email addresses. We've created some Excel spreadsheets that are pretty basic, but they give you the ability to put in data. The consumer can have the Excel spreadsheet themselves, but to put the data in so that then you can have charts and you can look at time 1, time 2, across the domains, and are things changing up or down? So it's visually easier to see and have a conversation about, these domains of recovery seem to be moving in the upward direction, but these are not, and what's happening here? Let's explore that more. So again, conversation is critical to it being used in a recovery oriented way. So here's some things that we've learned along the way in the last, it's been basically 10 years that we've been developing and testing and learning from people on the ground about using the RAS-DS in practice. So it enhances recovery oriented practice when or because of when the service user is engaged and supported to take a leadership or at least a very active role in assessment, and that completing the RAS-DS is genuinely you value it and they know you value it, and then they are genuinely, they identify as being a partner in that process or a leader in that process, rather than it being a pesky little tool that you apologise for giving them that will go in the filing cabinet. Okay, so when it's meaningful, when that self-assessment then drives goal setting and intervention planning, as I said before. When the RAS-DS is used as a conversation starter, when it's not just about filling in the tool, but that is a kickstarter to deeper conversations, to gain a deep understanding of what the person is experiencing experiencing and feeling. And as I showed you before, it's often a two-way learning experience. So consumers just having that opportunity to contemplate and think about those questions, get a deeper understanding of themselves, but equally you get a much deeper understanding of them and their perspective and their experiences. It's a really useful tool, and we hear this over and over again, really useful tool to develop that positive relationship, that rapport with the people you're working with. And we know that positive therapeutic relationship or alliance is so key, so central to good outcomes. So using the RAS-DS helps us to recognise and celebrate successes. So, and that's not just at repeat times, it's at the very first time, stopping and celebrating, not just honing straight in on those things that need to be, that we can change because they've scored lower, but really what are the things people are scoring high on, and sort of celebrating those achievements or that success, or it's celebrating those strengths. And it also facilitates us to really hone in on and focus on what the individual we're working with prioritizes. If we ask the questions of which of these are most important to you, do you care about this? You might have marked it low, but you might not really care anyway. But this thing that you've marked a 3, you might be desperate for it to come to a 4. So what is it? What thing that could we change that would make the biggest difference to you living the best life, the most meaningful, valuable life you could live? What do you want us to focus on? Those kind of conversations are so important. So a few more things we've learned along the way. The written word is golden, and I've said this in the other video, so apologies if I'm repeating myself a little bit, but we used to get RAS-DS data on paper-based forms, and people used to, the joy I would feel when people had written essays all around the numbers that they'd scored to explain and articulate their thinking around their score and that item, and it was just showed so much engagement with the questions, and it's fantastic. So what we've created is a RAS-DS Plus version, and it's on the website, and that leaves a space for comments for service users or consumers to fill in if they want to, if they want to make comment and remind themselves of why they scored things in certain ways. We've learned that people really do need to see their results, and the visual is better than the numbers for most people. So being able to map it and graph it is just so valuable, to be able to see the difference across the 4 domains, but also to be able to see change over time and think about that and what makes sense of what they're seeing. And again, as I've said, we've got Excel spreadsheets. They're a bit clunky, but they're fine. And we're happy to send them out to people, or maybe you can do your own better than we've done. As I've said before, conversations is where the magic happens. Understanding what's important to the person, again, might not be the thing they mark lowest. It might not be the thing they mark lowest that they most want to work on. I'm repeating myself here a little bit. So that collaborative interpretation, again, I really want to hone in on this. So in the video on using and scoring the RAS-DS, I gave an example of how a score that drops over time may well not be a negative. It might mean that somebody has been homeless. I'll give a different example. So someone might have been homeless for a long period of time. But they had a community there, so their scores in terms of connection and belonging were quite high, but they weren't doing things they felt were meaningful or valuable, or they were struggling in terms of managing their symptoms, so their Mastering My Illness scores were lower. And then you might measure that this person might do the RAS-DS 6 months later, and in that period of time they've moved into housing. And so scores around managing their illness, scores around doing things I value. The functional aspects of recovery might have really shifted upwards, but we could see that connecting and belonging scores drop, so they've moved away from their community. They might feel quite isolated and lonely because they've shifted into a different community that they're not yet connected to. So for many reasons, scores might make a lot of sense, but it's the share, coming together and talking and interpreting that, trying to investigate it together and understand what is happening and make sense of it together is critically important in terms of being recovery oriented. So one of the resources that will help you in terms of being recovery oriented with the way you use the RAS-DS is if you're a bit stuck in terms of you've set the goals, or you've used the RAS-DS, you've had great conversations, you've then develop goals around those areas that the person wanted to work on, but you're really struggling with what actions help them meet those goals. We've had a number of people internationally sort of email us saying, how do I don't know how to support them with that next step. And here's one potential tool that will help you and them see if this is helpful for them. So it's a workbook. It's got 4 sections, and the 4 sections align with the 4 domains of the RAS-DS. And there are lots of practical tool activities that will that you might find useful. I think I said in the last video as well, this workbook is used both for group programs and individual programs, and there's an American version if people prefer that to the very clearly Australian one. It's got a lot of Australian examples. Yeah, so that's all. This is where you can access it. I'm sure you know that because you've looked at this video, but certainly there are other resources on the website, so please explore. And you feel so welcome to contact myself or the RAS-DS team via email if you want help in terms of using the Excel spreadsheet to make the consumer's data more visible, or anything else you've got questions about. So look forward to hearing from you. And these are a series of papers that we have done with the RAS-DS, studies we've done, and there are quite a lot of these are available on the website, and there are others that I haven't listed here. So have an explore. Thank you.